Okay, well, good morning or good afternoon, everybody. And it's my pleasure to welcome all of you, those here in person and those who are with us remotely, to the 2023 start of the monthly lecture series. So happy New Year to everyone. And those who are participating remotely, we do want to hear from you, so submit your Q&A remotely, and Charlie Brooks will get the questions up to our speaker. And we are really in great shape to kick off the series with Tracy Smith, who is just an outstanding investigator whose work I admire greatly. And I am going to have one of our VCBH investigators, Eli Klemper, come up and introduce Tracy, and then we will get going. So, Eli.
Thanks, Steve. So thanks, everyone, again for coming. Really excited to have Tracy come talk today. Dr. Tracy Smith is from the Medical University of South Carolina. Tracy got her PhD at the University of Pittsburgh, where she studied with Eric Donnie before she went to MUSC to do a postdoc with Matt Carpenter, which many of you will recognize, and then transitioned to assistant professor in 2018. Tracy won the prestigious Jarvik Russell Early Career Investigator Award in 2020 from SRNT. And in looking over her CV last night, it's clear it was well-deserved. So she has numerous high-impact papers, but the one that really jumps out to me is the 2018 preventive medicine paper talking about the push and pull with reduced nicotine cigarettes and e-cigarettes. And this is a paper that shaped the way that I think about harm reduction in tobacco regulatory science. So if you haven't read it, recommend it. It's fantastic. It really deals with what I think are the most important issues in our field. Perhaps most impressive, Tracy is about to receive funding for not one, but 3 R01s on which she's PI or MPI. Anyone who's applied for a grant knows that's no easy task. So clearly, a rising star in our field. So I recently had the opportunity to work with Tracy and her colleagues at MUSC and was really struck by the thoughtfulness and the hard work that went into our collaboration, qualities that are not easy to find in a collaborator. So really happy that you came to talk today, and looking forward to hearing your talk on tobacco regulations across the Continuum Park.
Thanks, Eli. I got it. Yeah. Thank you so much, Eli. Thank you for introducing me and inviting me to come. Thank you, Steve. It's been a pleasure to get to meet some of you already, and I think I get the chance to chat with more of you later, so I'm excited about that. You'll see in my talk today, but it's kind of a combination of the work that I've done most recently over the last, 5-ish years, and the work that's ongoing, and then I saved some time at the end to talk about those 3 R01s. So I'm just excited about the new work as well. And so I wanted to share that with you guys, and hopefully it'll give you kind of a picture of like where I'm coming from, where I'm headed, all those things. So I don't think I need to tell this group that cigarettes kill people, and they kill a lot of people. They are still the leading cause of preventable death in the United States and worldwide. And I think sometimes there's the impression that it's not anything we can help or do anything about, that people don't want to quit if they're still smoking. But the vast majority of smokers want to quit, and most smokers try to quit every single year. They just can't, because quitting smoking is really hard. And cigarettes are by far the most harmful tobacco product out there. And that's because the bulk of the harm from tobacco comes from the combustion. It comes from the actual burning of tobacco. So products that are combusted, like cigarettes, but also other combustible tobacco products, are the most harmful. And so when I think about how to regulate tobacco and where we can have the biggest impact, the regulations that reduce the prevalence of smoking are those that are going to have the greatest impact, because that's where the bulk of the harm comes from. So I know e-cigarettes are kind of like the sexy, trendy topic right now, and I'm going to talk about e-cigarettes a lot because I think they're interesting. But in terms of like where we really have the most opportunity to do good, it's really in in reducing the addictiveness and the appeal of the most harmful tobacco product, which is cigarettes. So a lot of my work has focused on potential FDA regulation that would reduce the addictiveness of tobacco. And I think most people in the room and probably online are familiar with this intervention. But the idea is that if nicotine is the primary addictive constituent in tobacco products, all tobacco products, and that's why people are smoking, because when they smoke, nicotine is delivered to the brain and then they're more likely to smoke again in the future. If we could reduce how much nicotine is in a cigarette to a very, very low level, then the cigarettes would be minimally addictive or non-addictive, and people wouldn't smoke anymore if they didn't want to. They would now be able to quit if they wanted to do so, and in a way, giving people that freedom back to choose. So this is something that's possible through the Tobacco Control Act in 2009. This is Obama signing the Tobacco Control Act, giving the FDA the authority to regulate tobacco products, taking into consideration both current smokers as well as naive individuals. And this is the then FDA Commissioner, Dr. Scott Gottlieb, in 2017, announcing that it was something that the FDA was going to pursue. And it was kind of shelved for a few years after that when Scott Gottlieb left FDA, but it's something that last year the Biden administration announced they're going to pick back up. So it is something that the FDA is pursuing, this idea that we could reduce the amount of nicotine in cigarettes to a very low level, making them minimally addictive, and improving public health. So a lot of my research, a lot of the research I did in graduate school and my postdoc has focused on how a mandated reduction in nicotine content would impact smoking behavior. And in these types of trials, generally speaking, the way that they're done, and I think most people here are probably familiar with this, the way it works is we recruit current cigarette smokers and we assign them to a cigarette condition. We assign them usually to either a control condition where they get a research cigarette that has a normal level of nicotine in it. That's 15.8 milligrams of nicotine per gram of tobacco, or to a research cigarette that has a very low level of nicotine in it. And so in a lot of these studies, that's 0.4 milligrams of nicotine per gram of tobacco. And so they're research cigarettes. They all look the same. These trials are double blind. The people don't know what they get. We don't know what they get. And then we can ask them to only smoke the cigarettes that they've been provided with. So the goal is there to model a regulatory environment in which that's all they have access to. So you're asking them not to use anything else. And then you're looking at their smoking behavior across time. There's a menthol version and a non-menthol version. That's what you're seeing there on the screen. So this is an example from a clinical trial that I did with Eric Donnie at the University of Pittsburgh. I'll say that the data are remarkably consistent across these clinical trials. So I'm showing you one of the example. I'm showing it to you because it's the one I'm first author on. It's not the best one. It's not the largest one, but it is the consistent effect across time. So it's a good example. So in these clinical trials, we can look at the change in the number of cigarettes smoked per day across 6 weeks. This is the normal nicotine content group. So what you see is that when you give people cigarettes and you tell them to smoke as much as they want and they have a good amount of nicotine in them, they smoke more. And we call that the free cigarette effect. People smoke more when cigarettes are free. You can compare that to a group that gets a very low nicotine content cigarette. And what you see is that they smoke about 5 or 6 cigarettes per day fewer than the group that got the normal nicotine content cigarette, showing that when you reduce nicotine to a very low level, people smoke fewer cigarettes per day than the control group. And overall, this has been really, as I said, consistent across time. It suggests that if we were to institute a mandated reduction in nicotine content, we would likely see a reduction in the cigarette smoking rate among current smokers. So overall, very encouraging. Now, one of the most common criticisms I get for nicotine reduction surrounds compensation. And the idea is pretty simple. It's, well, if you give people cigarettes with less nicotine in them, won't they just smoke more? And if that were to happen, that would be a public health disaster, right? If people smoked more instead of less. This comes from light cigarettes, for example, that have been around a long time, where we know that when people get a small reduction in nicotine content, they do smoke more. And so it's a valid concern. It's something that we should work hard to address and make sure that it's not true. As I showed you from the clinical trial data, we don't see that in clinical trials, that there's a sustained increase in cigarettes per day. We actually see a reduction. But one of the problems with these clinical trials is that a lot of smokers are non-compliant. So as I said, we ask them not to use anything else while they're in the trial. We ask them to only use what we've given them because we're trying to model a regulatory environment in which that's all they have access to. But when we look at the end of the trial and we say, did you use anything else? What did you use? A substantial portion of people, about 40% of people in that low nicotine content group will say, yeah, I cheated. I used something else, at least a little bit. I used one of my normal nicotine content cigarettes. And in fact, when we look at the urine from the people in those trials and we try to estimate whether we think they used another nicotine product besides what we gave them, the rates are much, much higher. So the vast majority of people are cheating in these trials, at least a little bit, maybe not all their cigarettes, but 1 or 2 cigarettes per day, and they're lying about it. And that's complicated for a nicotine reduction standpoint because, again, we're trying to model a situation in which people can't just go to the store and buy their own Marlboros and smoke them. We want to know what would actually happen if people could only smoke these low nicotine cigarettes. And so there is some concern like, well, in a real world, if people could not just go to the store and buy Marlboros, would they then smoke 10 of the very low nicotine content cigarettes for every one? Or would they smoke 100 times as many to try to compensate for that low nicotine that they're not getting from another source? And this is difficult for us to address in clinical trials because we can't just lock people up and keep them from going to the store and buying their own Marlboros. And so the way that we've tried to address that is we did a study where we locked people up in a hotel and tried to prevent them from going to the store and buying their own Marlboros. So this is a trial where we recruited current cigarette smokers and we bring them into the lab and we search all their stuff and then we take them in a hotel or a bus to a hotel that's a smoking hotel. And while they're there, they stay in the hotel, nobody in, nobody out. And while they're there, we only provide them with the Spectrum Research cigarettes so that we can look at whether or not they would compensate in this environment where they can't just access their normal nicotine content cigarettes. While they're there, they eat all their meals in the hotel. We have them catered. We do a lot of games. We make friendship bracelets. We play Guess Who and Connect Four. And we monitor their behavior and a lot of subjective effects while they're there as well. So the design is pretty simple. We recruit people as a cohort of participants to come in together. They're there for a Monday to Friday period. Monday and Friday are half days. So it's really 4 24-hour periods, a relatively short period of time. And while they're there that first week, they only receive the normal nicotine content cigarettes, and they can use them as much as they want. They go home for a week, they wash out, and then they come back and they do the whole thing again, but this time they have the very low nicotine content cigarettes. So that allows us to compare their behavior during the very low nicotine content week to their behavior during the normal nicotine content week. The normal nicotine content week is the control. And ask whether there's compensation in this very low nicotine content week compared to the normal nicotine content week. And again, the difference from the clinical trials here being people cannot access their normal nicotine content cigarettes, so we're ensuring that there is no cheating. We wanted to make this as real world as possible. We wanted to prevent a ceiling effect, a situation where people just sit around and smoke all day because there's nothing else to do and the cigarettes are free. And so the way that we did that is that we created a cigarette store, but the only cigarettes for sale in our store are the Spectrum Research cigarettes. People get a bank when they come into the study and they can purchase cigarettes from our cigarette store out of that bank. Any money that's left over at the end is money that they get to take with them. So it is real money. There is an incentive not to just sit around and smoke all day. So these are the data. What's plotted here is the number of cigarettes smoked per day across the 4 24-hour periods. And you can see the dark line is the normal nicotine content week. The dashed line is the very low nicotine content week. So there's no significant difference in any of the days between the very low nicotine content week and the normal nicotine content week. To me, it looks like there might be some increase on day 2. It's not significant, but it's certainly gone and not sustained through days 3 and 4, which is reassuring. We also tracked CO while they're in the hotel. We take their CO 4 times a day, 8 a.m., 12 p.m., 4 p.m., and 8 p.m. This is the normal nicotine content week, and I've broken it up by day. You can see just the pattern throughout a day and someone's carbon monoxide, which is a measure of short-term smoke exposure for anyone that's not familiar. So in the morning, it's relatively low, and then it goes up by noon and stays consistent throughout the day. That's just like a normal pattern as people are smoking. And we can compare that to the very low nicotine content week. So again, there's no significant difference in CO across any of these time points, and there's no interaction. But it does look to me like there might be an increase in carbon monoxide across the second and the third day that people are in the hotel that's gone or even reversed by days 4 and 5. So overall, no evidence from these data that there's sustained compensation, that people are smoking more to make up for that lack of nicotine in the very low nicotine content week, especially after the first couple of days. So we try to answer these questions as thoroughly as we can possibly answer them. So one of the things that we did while we were in the hotel is we collected everyone's cigarette butts while they're in the hotel. So when they're done, they keep track of all their cigarette butts and they turn them in. We sent them to our colleagues at the Centers for Disease Control who are able to analyze them for solanosol. Solanosol is a terpenoid that's naturally present in tobacco, and when you smoke, it's deposited into the filter. So you can look at the filter and measure the solanosol and have a sense of how much smoke exposure came from that cigarette when the person was smoking it, which is pretty cool. This paper was led by Cassidy White, who's a trainee who worked with me on this project. And so what I'm plotting here is the percent change in puffing intensity across the 4 days. And so again, the change in puffing intensity means how much more intensely they smoked that cigarette at the per cigarette level. So average, ignoring cigarettes per day, at an individual cigarette level, did they smoke the cigarette more intensely during the very low nicotine content weeks? Maybe they're trying to get as much nicotine out of each cigarette as they can. And these are those data. Kind of light on the screen. I hope you can see it. What you're seeing is that on the first day, it certainly does look like people smoked more intensely. And actually, all of these confidence intervals are above 0. So there's about people are smoking the cigarettes about 40% more intensely in that first day. And then you see a trend, it's a significant trend that the increase in puffing intensity decreases across the 4 days. And by day 4, it's really quite small. Now, if we'd run this out further, more than 4 days, the question is, would it have gone to 0? And I don't know the answer to that. I do know that the expired carbon monoxide, again, which is a measure of short-term smoke exposure, was not significantly increased. So it may be that these increased smoking intensity may be offset maybe by some reductions in cigarettes per day across time, but overall people were not exposed to more smoke as measured by carbon monoxide by the end of the trial. Now, again, you've got people in a hotel for unlimited time during those 4 days. So we collected as much data as we could. And one of the things that we did is that my colleague, Rachel Denlinger-Apte, who's now at Wake Forest University, she was at Brown at the time, she conducted individual qualitative interviews with each participant while they were in the hotel to ask about their experiences smoking the cigarettes and their experiences and how they're feeling. We told the participants that the cigarettes had very low nicotine in them, which is a little bit different than a lot of the clinical trials. And then we did that because we wanted to potentially incorporate expectancies into the equation. So in the real world, if a regulatory nicotine reduction policy is implemented, people will know, and that could contribute to compensation. So we wanted to allow for any opportunity to observe compensation if it was there. And so one of the questions she asked people is, what did you think when we first told you the cigarettes have less nicotine in them at the beginning of the week? We told them at the normal nicotine week, they have normal. We told them in the low nicotine week, they have less. What did you think? And so these are some of the quotes. I would encourage anyone who's interested to read the paper that she led on this. It's in Drug and Alcohol Dependence. All of the quotes are really interesting and really eye-opening across a variety of topics. So just a sampling of them. So one participant said, my initial reaction was I'm going to have to smoke probably 2 to 1 or 3 to 1 just to get the same amount. One participant said what my thoughts were and what the reality was is 2 totally different ideas. You know, my thought was they're going to be nasty. You're not going to even taste anything. I'm going to smoke like a freight train to try to make up for the nicotine my body is craving. And it didn't even come out that way. One participant said, I was just thinking I would have to keep lighting up cigarettes back to back just to get like 5 cigarettes. I was thinking just to feel like I smoked 1. But then, and after trying them, it wasn't like that at all. And then my favorite participant who just simply said, I was thinking, oh. And so overall, the participants reported that they thought they were going to compensate. That was really common across all of the participants, that they thought when they were told that they have less nicotine, they don't have the language or the jargon, I guess, to say compensation, but they thought they were going to need to smoke more and were surprised that that didn't turn out to be true. We did ask participants about withdrawal, which is something I get asked all the time about this study. You have them in a situation where they're not cheating at all. How much withdrawal is there? And I guess what I would say is surprisingly little. So we've got a couple of quotes from people about how they were feeling, their physical feelings and emotional feelings. We had a participant who said, I've been like, I'm not freaking out. I'm not upset. I'm not depressed. I feel kind of tired though, kind of drained. A participant who said, I would say I feel the same as I always do. If anything, I've been more hungry. A participant who said, I've been slightly more irritated. And overall, that tracks with what we see in the questionnaires, which is a lot of mood-related withdrawal reported and a lot of sleep-related withdrawal reported on the questionnaires, because we did do some of the more objective questionnaires as well. One of the most interesting things to me is how much people were reporting that they feel less dependent. And in that way, it's really kind of inspiring. Again, it's worth noting it's not blind, right? People know that the cigarettes have less nicotine in them, so it's hard for me to say what role that plays. But we were really encouraged by how much people were saying that they felt less dependent. So one of the participants was expressing at the end, when I go home, I'm thinking, do I not even smoke when I get back in that car? Should I do that, or do I pick up another cigarette? Because I think I could actually quit now. So expressing some hesitancy about going back out into the real world. A participant said, I find I'm able to play cards without dying for a cigarette, to go and read a book without having that cigarette in my hand. I'm not having the urge to literally keep that cigarette pack near me. And then a participant who said that they smoked more on Monday, a decent amount on Tuesday, but once Wednesday got here, my cravings for wanting to smoke and needing a cigarette really came down. It's like the desire to need a cigarette is not as strong. So I would encourage people to read that paper if they're interested. There's a ton of really interesting quotes that came from that study. So I don't have time to show you all the data on nicotine reduction, and a lot of you probably know a lot of this literature, but just to summarize, the data on nicotine reduction is really very strong. The body of work that's been built surrounding this idea is really strong. And so all this data did not come from me, but there are strong data showing that a mandated reduction in nicotine content would likely reduce cigarettes smoked per day among smokers who are unmotivated to quit. There's a lot of clinical trials on that now. It's unlikely to produce sustained compensation. I showed you some of those data, but there are a lot more as well that have been generated. There are data suggesting that it's likely to reduce initiation among individuals who are naive to nicotine. There are a couple of good trials showing that it's actually likely to increase cessation among smokers motivated to quit, which is ultimately the most powerful thing, right? It's not just that they smoke less, but that they quit. And a lot of this work has been done here. There are quite a few trials now showing that there are similar effects that have been observed across a variety of vulnerable subpopulations that you might worry about, and no safety concerns. So in addition to nicotine reduction, as I said, the interventions that are going to be most powerful are going to be those that reduce the appeal and the addictiveness of combustible tobacco. And there are others that I think are important besides nicotine reduction, although I think nicotine reduction is probably the biggest impact. And so, for example, a menthol ban is something that FDA is considering, and I'm going to talk more about that later related to my future work. So keep that in mind. So in addition to all of this, the interventions that can reduce the addictiveness and the appeal of the most harmful tobacco products, which are combustible products, as those interventions are implemented, it's likely that people will move down the continuum of harm. And ideally, that's moved towards abstinence. They're not using tobacco at all. But for a lot of people, it may mean moving towards less harmful products like e-cigarettes. And e-cigarettes are less harmful because they're not combusted, which again is where the bulk of the harm comes from. This class of products is complicated to regulate for the FDA, to say the least. And that's because, in spite of the fact that for smokers, they're less harmful. And if smokers could switch completely to an e-cigarette, it would reduce their long-term harm. They're also not safe. And so for people who don't use e-cigarette, who don't use tobacco at all, especially kids, they're products that potentially result in increased harm and that we'd like to stay away from. So that puts the FDA in an awkward position of trying to regulate e-cigarettes and other non-combustible products with both populations in mind. Ideally, FDA should have these products out there and available and appealing for adults who can't quit smoking to serve as substitutes. However, having them out there and appealing and addictive is harmful for public health for adolescents who maybe would not have otherwise used tobacco. So I don't think I need to tell folks in the room that e-cigarettes have been increasing in prevalence over the last decade. They're now the most commonly used tobacco product other than cigarettes among adults. And for adults, they are still now, they are most commonly used among current and former smokers. So most of the use among adults is among people who are currently smoking, they're dual using, or they used to smoke and potentially they've transitioned to using e-cigarettes. But this varies a lot by age. So for young adults, most use is among non-smokers. So that's use we'd want to avoid, right? Because those are people who weren't using tobacco and now they are. But for older adults, it's like among former smokers and current smokers. So a lot of my research over the last several years and some of the upcoming work that I'm doing has really focused on the potential benefit for adults, what the impact is of these products on cigarette smoking for adults who are currently using the most harmful tobacco product that's available. So I've done a number of pilot studies on this, on e-cigarettes and the potential impact on cigarette smoking. We did one pilot study where we looked at the impact of e-cigarettes on cigarette smoking across a 3-week period among smokers who we didn't ask to switch. We just provided them with an e-cigarette for a 3-week period and told them they could use it as much or as little as they wanted. And so in this trial, it's a small study. We had a group that just was told to smoke as normal, and then we had 2 groups that were given e-cigarettes. We gave them 2 different kinds of e-cigarettes because we thought that the kind of e-cigarette may matter in terms of its impact on cigarette smoking. So one group got Juul, one group got a mod. And for those who aren't familiar, a Juul is an e-cigarette that has a very low wattage but very high nicotine concentration. There's no customization. It's plug and play, really easy to use. So from that standpoint, we thought that might be appealing. But we also gave one group a mod device, and that's a device where they could adjust the wattage themselves. It's really highly customizable. They could choose the nicotine concentration, choose the flavor, all of that. And so our question was how e-cigarettes impact cigarette smoking when people are not given specific instructions to switch. So they're just kind of provided with the device. They didn't have to want to quit, and they're just told to use it as they'd like. And so these are the data, what we found for e-cigarette use. So what's plotted here is the number of episodes of e-cigarette use across a 3-week period. And so what you're seeing is that people in the e-cigarette groups use e-cigarettes more than the control group. There was someone in the control group who went out and bought their own e-cigarette. So that's what you're seeing there is a little bit of use at the end. And it does look like people are using the people in the Juul group used it more often by the end. That was a more appealing device. And so then we looked at the corresponding change in the number of cigarettes smoked per day. So this is change in cigarettes per day from baseline. And what you see is the group that didn't get an e-cigarette is unchanged. There's no change in cigarettes per day. There's a reduction in cigarettes per day for the people that got e-cigarettes. And that reduction was largest for the people that got the Juul, suggesting that the Juul seems to have been more appealing than the mod, and people used it more. And that changed their smoking more, showing this kind of relationship between use of the e-cigarette and reductions in cigarettes per day. We also asked about whether or not they tried to quit smoking during that time period. Again, these are not necessarily people who wanted to quit. We didn't ask them to quit or to try to switch. And what you saw is that nearly 50% of people in the Juul group did report that they tried to quit smoking during the trial. And the changes in carbon monoxide were largest for people in the Juul group as well. So these data suggesting in this small pilot trial that e-cigarettes can reduce cigarette smoking even when people don't have explicit instructions to switch. So we didn't tell people to switch, and they get nearly 50% of people trying to quit smoking in the Juul group is potentially really powerful. It also looks like the device matters, right? Like it matters whether it's a good one that you like or not, which makes sense, right? It needs to be reinforcing enough to compete with the highly reinforcing product of a cigarette. So there's other data that have come from our group as well as others. The most recent Cochrane review now says that e-cigarettes and randomized trials do help people quit smoking. So the data based on the body of data on this is really growing and gotten strong over the last several years. My colleague at MUSC, Matt Carpenter, who's also the primary mentor on my K Award, has done a number of trials where he gives out e-cigarettes as well as other products to cigarette smokers and just sees how it affects their behavior. So these are data that come from across 3 different studies of his that he did, where he gave out either NRT, varenicline, or e-cigarettes to people and told them to just use them as much or as little as they'd like over a period of 4 weeks. And at the end of the 4 weeks, he is looking at whether or not it changed their cigarette smoking and whether or not they quit smoking. Again, not necessarily people who want to quit smoking. And what you see is that the e-cigarettes were better across studies. This is not in the same study, at helping people abstain from smoking than the pharmacotherapy. So this is a little bit off topic from FDA regulation, but I think one of the next steps for us as people who are thinking about this work is whether or not e-cigarettes better help people abstain from smoking than FDA-approved pharmacotherapy when people are instructed to switch. So again, there's quite a bit of work coming out of the UK on this. Peter Hayek has led a number of trials comparing e-cigarettes to nicotine replacement therapy. The work's been a little bit harder to do here in the US because of regulatory hurdles. But I have a couple of trials on this that are ongoing or growing. So I have a pilot trial right now where I'm recruiting cigarette smokers who have already tried with FDA-approved pharmacotherapy and failed. And I think that's important, right? Like, I'm not suggesting we hand out e-cigarettes to people who haven't tried what's best for them. It's FDA-approved first. But if you've tried that and it didn't work for you, then we should be thinking about reducing your harm at a minimum, and switching to a less harmful product is a way we can do that. So this is a small pilot study where we are currently recruiting 30 people who've tried and failed to quit smoking. They're either going to get an Enjoy ACE or they're going to get combination nicotine replacement therapy. Everybody's going to sample it for a week-long period in the time period before they try to quit. And then everyone is setting either a target switch day if they're in the e-cigarette group, or a target quit day if they're in the NRT. And yes, I recognize that's mostly jargon and language. And on that day, they're told to stop smoking and use their assigned product exclusively for a 4-week period. During that 4 weeks, everyone's doing daily diaries. And so we currently have 13 people enrolled in this trial. I'm really excited to see what the outcomes are. And the purpose here is really just feasibility and making sure that this is a trial that we can do. One of the trials, this is a little bit moving into my future work, but one of the trials that received a fundable score that I'm hoping will be funded in the near future is a larger version of this trial where we're going to recruit 225 smokers who failed to quit with FDA-approved pharmacotherapy. And those smokers are going to be assigned either to a switch group where we're trying to reduce their harm, where they're going to get an e-cigarette. They get to choose what e-cigarette they get. Open to suggestions on this. Right now I'm thinking about the Enjoy ACE and Juul. Or they get assigned to try to quit again with FDA-approved pharmacotherapy. People who are assigned to quit again will choose between combination NRT and varenicline after receiving information about both and making an informed decision about what they would prefer in terms of their best quit method. They get, they're going to still get that 1 week period where they get to kind of sample and try whatever they'd like, and everyone sets a target switch day or a target quit day. It's an 8-week intervention, so I'm going to give them 8 weeks of product, and then encourage them to get more if they'd like, as you would advise anyone who was on medication to do, to get more if it's helping them and they feel like they need it. And we'll follow them for up to 6 months. And so in that trial, our outcomes are self-reported tobacco and medication use, expired carbon monoxide, but we're also going to collect urinary NaOH and respiratory function measures, self-reported respiratory function as well as spirometry. And that's because if more people abstain from smoking with e-cigarettes, but e-cigarettes aren't as good as abstinence, I think it's important for us to measure for example, the respiratory improvements. So the respiratory improvements may not be as good as the group that quits with NRT and varenicline, because those people are off tobacco altogether, right? So you're potentially, it's potentially a trade-off of more people getting off cigarettes, but the improvements not being as large. And I think it's important for us to have data to tell us about the potential trade-off. So as I showed you, there's data showing that e-cigarettes potentially help you stop smoking, and potentially the type of e-cigarette matters. And that is really important information for FDA, because FDA is trying to regulate these products with information about whether or not they should be left out there and appealing, and what products need to be pulled off the market. And so products that help people switch potentially offer more benefit. If the product does not really help people switch, there's not really any good use for it out there on the market. It's potentially detrimental to kids, FDA could just remove that from the marketplace. So one of the things that I'm interested in is what are the determinants, both at an individual level, but as well as at the product level, of whether or not a product actually helps someone switch. And so that's the focus of my K Award. So I wanted to tell you a little bit about the work I'm doing on my K. So so in thinking about what determinants help people switch, which ones are likely to be important, any determinant that influences the reinforcement value of that e-cigarette is likely to be important. If it's going to help someone switch, it needs to be relatively enough reinforcing compared to cigarettes to compete with cigarettes for a motivated smoker. So if a product is reinforcing, then it's likely that people will use it. There'll be uptake of that e-cigarette, and then it can reduce cigarette smoking. And so in terms of what we know contributes to reinforcement, we know nicotine delivery contributes to reinforcement, and we know sensory motor cues contribute to reinforcement. So that's really where I wanted to think about the characteristics that influence those outcomes. And so the two characteristics for my K Award that I focused on are e-liquid nicotine concentration and device power. And that's because e-liquid nicotine concentration and device power combine to influence the delivery of nicotine to the user. So a lot of people talk about just, well, I have a 5% or I have a 2%. And that's important. Nicotine concentration is important, but it is in combination with the power of the device. So a very low nicotine concentration can deliver high levels of nicotine if the power of the device is high enough, right? So those two characteristics are the ones that I decided to focus on for my K Award. And so for this study, we are recruiting cigarette smokers. It's a 2x2 design. So cigarette smokers are recruited and they either get a low or a high nicotine concentration device, and they either get a low or a high powered device. The cool thing about this is we're using a mod, which I don't love because I already just showed you data that people don't like this as much, right? But the mod means that we can use the exact same device in all of the conditions and that it can be double blind. So it's the same device and we set the power of the device for the individual and lock it so the user can't change it and then remove it from the screen so they don't know what it is. And then we provide them with nicotine liquid that is blind and it's either low or high. So all 4 groups in the study are getting an e-cigarette. They're all getting the same e-cigarette and they're told, we give it to them at baseline when they do a choice test and behavioral economics outcomes. And we tell them to use it as much or as little as they'd like over a 3-week period. And then they bring the device back at the end and they do those same behavioral economics assessments. And so this study is blind and it's ongoing. We currently have 74 people in the trial, so I can't break the blind for you, but I do have a little bit of data that I can share. So what's plotted here is the number of cigarettes per day that are smoked across the 3 weeks. And so for this graph, I've combined all of the groups together. Again, everyone's getting an e-cigarette. So there is a 30% reduction on the whole in these 74 people in cigarettes per day across that time period. And then this is how the cigarettes per day look like by group. But I've left the blind on. So this is the percentage reduction in cigarettes per day for nicotine concentrations A and B and wattage 1 and 2. And again, hopefully I'll come back in a couple of years and I can show you with the blinds off. But it does look like certainly these 2 device characteristics matter. They influence changes in cigarettes per day. And it seems like there's probably likely an interaction as you would expect since they moderate each other in terms of nicotine delivery. So on the whole, e-cigarettes among adults are most used among current and former smokers. They do have the potential to reduce cigarette smoking and dependence. I didn't show you that data in adult smokers, even without explicit instructions to switch. And I think that we need, as a field, really to have a better handle on what it looks like when people are making intentional efforts to switch in different contexts for different populations with different devices so that we can have a better understanding on what works, what is the potential benefit of these products, and potentially get things off the market that don't have that benefit. Device characteristics are likely important and nicotine is likely critical. I think that it would be helpful for us to know what level of nicotine is required and potentially how that compares to the level that adolescents find appealing, because ideally we would like it not to be addictive or appealing to adolescents. And as I didn't talk about this today, but e-cigarettes are popular among non-smoking youth. We've published papers showing that nearly half of adolescents who vape report that they want to stop. and a quarter of them have tried to stop in the last year, and they didn't or couldn't. They're still vaping. I don't know if they couldn't or didn't. And so I think that it would be that we need significant resources in developing interventions for those adolescents who want to quit vaping and can't. Because the goal should be to help people get off nicotine if that's what they want to do, right? So I hope you'll hear me a little bit. I want to talk about the two other RO1s that are pending that I'm excited about doing over the next few years, so you have a sense of where I'm headed. So as I mentioned before, the bulk of the harm from tobacco really comes from combustible tobacco and combustible cigarettes specifically. And I talked about nicotine reduction as an intervention that can reduce the addictiveness and the appeal of these products. Another one that's out there that I think FDA is above nicotine reduction and FDA's agenda is menthol. So menthol has been around since the 30s. The first brand of menthol cigarettes was Spuds cigarettes. And over time, it's become a greater portion of America's tobacco market share than before. So these data come from Christel Novo, who's published along with Andrea Valenti and others that a lot of the gains that we have made in reducing the prevalence of cigarette smoking over the last couple of decades have come from non-menthol smokers. And the rate of menthol smoking has stayed relatively consistent. And so because of that, menthol smoking is making up a larger percentage of our market share. And so there's a lot of opportunity there for us to make progress for those individuals. So why do people want to ban menthol? A lot of the data on menthol comes from cross-sectional studies or data from other countries. So there's a lot of cross-sectional data to suggest that menthol may increase smoking initiation. Youth and new smokers are more smoke menthol cigarettes. And that's something that we think that it's a starter product. When you ask people what the first product they used is, a lot of times they say menthol. The second reason is because menthol may increase cigarette dependence and hinder quitting. And so this comes from data where we know that menthol smokers are just as likely or more likely to try to quit smoking, but they are less likely to be successful at quitting smoking. When you look at cigarettes per day, they don't smoke more cigarettes per day, people who smoke menthol cigarettes, and they may smoke fewer. It does seem like they smoke potentially fewer cigarettes per day. But their first cigarette in the morning is sooner, which is often thought of as a good single item measure of dependence. And we know that they're less likely to be successful when they try to quit. The other thing is that it's a health equity issue. So menthol contributes to a lot of disparities. People talk about this, especially with regards to African Americans in the United States. So the majority of African Americans who smoke use menthol cigarettes. 80% of African Americans who smoke use menthol cigarettes. The majority of menthol smokers are still white, but the majority of African Americans who smoke use menthol cigarettes. And then menthol smoking is also more prevalent in a lot of other populations that might be considered vulnerable, including women, members of the LGBT community, individuals with low income, individuals with low education, and those with comorbid mental illness. So as a result of all of this cross-sectional data, the FDA has announced that it's something that they're pursuing. And I think that they're aiming for the proposed rule to be out sometime this year, is what I've heard. And if FDA implements such a policy, there's a lot of different outcomes or changes in behavior that could take place. So for people who are current cigarette smokers, they could change the number of cigarettes per day that they smoke. They could switch to non-menthol cigarettes and smoke more of those or less of those. They could quit if they don't like the products that are out there and available, or they could switch to another product, especially if menthol is still available in e-cigarettes, for example. That is all likely to be moderated by whether or not menthol is still out there for e-cigarettes. So if menthol is still available in e-cigarettes, maybe it's more likely that people will switch to another product, which could be good if they do that instead of just switching to non-menthol cigarettes. It also could be bad if they would have otherwise quit smoking. And so it's kind of a question mark in terms of the impact of these two interventions on public health. All of those things are likely to be combined and moderated by demographic variables to determine the overall population impact. So for one of the RO1s that's pending, I'm interested in how a menthol ban would impact smoking behavior, switching to e-cigarettes, and quitting. And so the design of this trial is that we're going to recruit 240 smokers who are menthol smokers, and they'll be assigned to a cigarette condition that's either menthol or non-menthol. So we are going to use the spectrum cigarettes, but the normal nicotine content spectrum cigarettes. And the reason for that is because I don't want one group to switch brands and the other one not. And that would be a confound. So everyone's going to switch brands. Everyone's going to use the spectrum research cigarettes. And they're either assigned to a menthol or non-menthol version. Again, modeling this regulatory environment in which that's all people have access to. Everyone's also going to get an e-cigarette. They're either going to get menthol or tobacco flavored e-cigarette. And for this, we're proposing right now to use the Enjoy Ace, either menthol or tobacco. And so they're going to have access to that. And that creates 4 conditions. It's a 2x2 design. People who get a menthol cigarette and a menthol e-cigarette, that's the status quo. It's as if there is no ban. They can use whatever preferred menthol product they want. People who get non-menthol cigarettes and menthol e-cigarettes, that models a menthol ban for cigarettes only. People who get non-menthol of both, that models a menthol ban for both conditions. So FDA institutes a menthol ban, they remove menthol e-cigarettes from the market. And then people who get a menthol cigarette and a tobacco flavored e-cigarette, that models a situation in which all flavors have been removed from the market for e-cigarettes, but the menthol ban is not implemented. And so for this study, there's going to be a usual brand period where people smoke their usual brand as much or as little as they want. And it's provided for free. They get their assigned study products for 6 weeks. And we ask them to only use the products that we provide to them for that 6-week period. And then because of the fact that we think menthol influences people's ability to quit, or there's cross-sectional data to suggest that it reduces the ability to quit, there's going to be a week-long period where people are asked to try to quit smoking and they're incentivized to do so. And we look at time to lapse and whether or not the menthol ban influences times to lapse. Everyone also has the option to take home NRT if they want to at any point in the trial. So they're welcome to try to quit smoking. It's not like e-cigarettes are the only other option that we gave them. And for this study, we're going to look at all of the outcomes that you might expect. And I'm working with a couple of great statistical people who are going to use the data to calibrate the effect to the US population using PATH data, and then model the effect on life years saved and deaths averted, which should provide great data to FDA about the public health impact. The last thing I want to talk about is the second trial, the third trial, which is really about this class of products, e-cigarettes, and people who potentially are switching from cigarettes to e-cigarettes because they're less harmful. So as I mentioned, FDA is trying to regulate these products with both populations in mind, and ideally they should be appealing, but not too appealing, not appealing to kids, but still appealing to adults. And there's no regulation that is more contentious and controversial than e-cigarette flavor regulation. So we know that flavors are really appealing to kids. We know that that is one of the reasons that kids report that they tried an e-cigarette, and it's one of the things they like about e-cigarettes. We also know that adults report that they like the non-tobacco flavors as well, and that it better helps them switch. And FDA has been reviewing applications from e-cigarette manufacturers, these PMTA applications, about whether or not their product can stay on the market over time, and they've made good progress on that. So they didn't. First thing they did was deny some flavored products right out of the gate. They have authorized a handful of products. The only ones that have been authorized by FDA are tobacco flavored. So they haven't authorized anything that wasn't tobacco flavored. They've now made progress on over 90%, actually I think it's 93% of applications, including issuing 1 million marketing denial orders to flavored products. And in those marketing denial orders, FDA said that the applications for these flavors lacked sufficient evidence that they have a benefit to adult smokers, and that benefit was substantial enough to overcome the public health threat posed by well-documented levels of youth use. And so they suggest that the scales have really been tipped a priori in the direction of protecting youth, and that we don't have enough data to show that these non-tobacco flavors provide a benefit above and beyond the benefit that's provided by just tobacco flavored by themselves. And so this is an application we're really interested in whether non-tobacco flavors better promote switching than tobacco flavors. And it's an, I'm going to skip this for time. So there's a lot of preliminary data to suggest that that could be true. This is an MPI application with Ted Wagner, where the trial is we're going to recruit a large nationwide sample of 1,500 people nationwide. And we are going to ask them to try to switch. They're either going to switch to a tobacco flavored, so they're basically assigned to a condition where non-tobacco flavors are not available, or to a condition where they get to choose their flavor. They have a preferred flavor, or to an NRT, combination NRT condition. Everyone in this trial is going to get 2 weeks where they get to sample those products in advance of switching, and they set a switch date. And they have 12 weeks where the product is provided, and they can use that product exclusively. That's what they're asked to do. If they can't use it exclusively, they're asked to reduce as much as possible. And then there's 12 weeks of follow-up. And so this trial will really help us answer the question of whether or not the non-tobacco flavors do provide a benefit to adult smokers above and beyond the benefit that's provided by the tobacco flavors. And so we'll look at all the outcomes you would expect for that as well. So in sum, FDA has the authority to regulate these products. The regulations have to consider both users and non-users. The most bang for your buck in terms of how we can have the biggest impact is going to be reducing the appeal and the addictiveness of combustible products, because that's where the bulk of the harm comes from. And then regulations that reduce the appeal of e-cigarettes and other products like that are complicated because they affect both users and non-users. And I just want to close by thanking all the people who've contributed to all of these wonderful projects and the upcoming projects as well. And here are my disclosures. Thanks so much.
Questions? Yeah.
You've walk big, picture, small, and bringing it back again. My first question, I'm sure I'll pepper you with more after I've given other people opportunities. First question is about you assign people to either cigarettes. Mentioned that the mods were customizable in terms of flavor, but I'm not sure if that meant that they were able to just kind of choose whatever flavor or able to choose their flavor.
Yeah, that's a good question. So for that condition, for that study, we did hold flavor constant. So people chose between, I think, just tobacco and menthol. And originally we were going to have more mint and something else, and then FDA banned mint, and we had to pull that one too. So we did try to keep flavor consistent. That's a good question. But they were allowed to choose different nicotine concentrations, and they did have a wide range of wattages that they could choose.
Yeah, we have a number of questions. Many of which not identified. You know, that there are any harmful chemicals in vape aerosols. In 2022 review articles are showing harm to multiple organ systems. How can it be said where on the continuum harm products are, i.e. whether?
Yeah, so they're certainly not as harmful, and I think the data on that are pretty strong. We know that when we look at a variety of different exposures in the urine of people who've switched completely, that all the toxicants that we measure are reduced. We also know that in terms of aerosol output, a lot of the toxicants that you might worry about have been reduced. We also know that people's respiratory symptoms improve. There's improvements in short-term measures of health, like heart rate and blood pressure, things like that. Now, does that mean that there aren't long-term harm things that we don't know about? Of course not. And that's why I don't think we should be handing out e-cigarettes to anybody who hasn't already tried to quit with an FDA-approved pharmacotherapy. But I think, specifically, I think for pulmonary stuff, that's where I think we're not going to see as much of the benefit as potentially in other areas, as well as I know that people worry about dental and mouth health a lot. And so, we certainly can say that they are less harmful. And I think to say that they're not, or that you think that they could be as harmful, ignores a very large body of evidence now showing that they are less harmful, showing reduced toxic air exposure and reduced harm for people. I also would never say they were safe. And I would never say that I want my kids to use them, or that, I think that that's something that we should be advocating for as a first line intervention. But I do think people are working hard to try to come up with a reason to believe that they're just as harmful. I think there's a lot of people are afraid to admit that they're less harmful, and that the data on that really are really quite strong. There's a couple of great review papers I'm happy to point people to if they'd like. But again, not to say that they're safe, and where they are exactly on that continuum is probably unclear. But we do know, and we've known for decades, that the bulk of the harm comes from combustion, and they're not combusted, right? So just that in and of itself goes a long ways.
Thanks for a great talk. My question, focus of your K award.
Yeah.
With
Yeah. So, I'm gonna repeat the question. So Eli asked, because I don't know if your mic was on. Eli asked whether or not salts play a role in nicotine delivery, specifically with regards to my K award and combining nicotine concentration and device wattage. You'll notice that the nicotine salt products are lower wattage. And that's because they're really high nicotine concentration. They deliver nicotine really effectively. But the fact that they're salt means that less of the nicotine is free, right? So anyway, I think it certainly does matter. I think there's a couple of people who are doing research on that. I think Tom Eisenberg group might be pursuing that. Specifically, they do really nicely designed studies on pharmacokinetics. So I think they're really high nicotine concentration, and that's balanced with a very, very low wattage to deliver. But I did do a study where I had the same nicotine concentration and a wattage and a freebase, and I found that people reported it to be harsher, but that they didn't use them differently, which surprised me. But we didn't have PK pharmacokinetics in that study. I think that would have been a really nice addition to that as well.
From Megan Fritsch, we have a free upcoming switch study. Is there a reason for choosing pod-based systems, Juul and Enjoy? I was just curious.
Yeah, I am interested in people's input on that. My preferred way to do that study, man behind the curtain on this, is that application was actually written to be a choice between e-cigarettes and IQOS, which is a heat not burn device, heated tobacco product. And IQOS is not, I can't buy IQOS anymore. And so for now, I'm proposing that it'll be a choice between multiple e-cigarette devices, and that if IQOS becomes available again, I'd love to include it. I think the element of choice is important, especially because the other group is getting a choice. So I really would like to rely on the products that are exclusively FDA authorized. And Enjoy is, because I think that people are much more likely to suggest e-cigarettes to people if it's been authorized by FDA as less harmful, which Enjoy Ace has. But I want it to be two that are appealing as well to people. And so there's really strong data that Juul is appealing to people, that people like it. It's a good substitute. And so that's part of why I relied on that. Hide and puff bar, I worried about puff bar a lot because there's some papers showing that a lot of the puff bars are counterfeit or they're not as well quality controlled wise. They don't all come from puff bar. And so I worried about that product being available for the duration of the study, like for a whole 5 years. But I am interested in it and open to people's feedback. Thanks, Steve.
So for the health study that you were describing to us, I was really interested in the activity you were describing. I'm wondering, do you have any like measurement or data about how engaged people were? Just kind of thinking from the framework of, you're providing a lot of like alternative reinforcing behaviors, and whether or not that's, the same as people in their natural environment.
Yeah, it's so true. I don't know. And, we could have done a better job measuring that, I would say. I mean, it's hard because the people who come into this, right, they have to be people who can leave their lives for a week, right? So you're already kind of working with a different population of people than might be recruited in the clinical trials, stay-at-home moms or people who work from home, or this is pre-COVID. So anyway, I don't really know. I would say that people anecdotally, we're very engaged. We work hard to make it like camp. Like we really try to make it like a fun activity where people are bonding. And people do seem to like it. We had a couple of people tell us, so this study, because it was a crossover design, it was really important that everyone came back. And that was the fear that they don't come back, right? And there were a couple of people who reported at the end that they really had initially not planned to come back. They were just going to take the money from the first week and walk. But once they got there, they felt invested and engaged in the other people and in us, and they could see how much we care and were invested, and then they decided to come back. But it would be great, I think, thinking about alternative reinforcers available there versus their natural environment, as also whether or not they took advantage of those alternative reinforcers more in the very low nicotine content week would be really interesting to reduce the reinforcement from smoking, right?
Thank you. That's very fascinating. And I think it also speaks to perhaps the importance of integrating behavioral interventions, maybe like group treatment and things like that, if that would also be an important part of helping people, have things to do other than smoke.
Yeah, right. Yeah, something to fill that time with. Yeah, thanks.
Show worse COPD landing on dual users. Does this also bring into question the use of the mere decreases in cigarette use as a measure of reduction of harm?
In dual users, is that what that says?
Yes,
dual users. Yeah. So I think the data on dual use is pretty clear, which is that the harm associated with dual use is correlated with how much they're smoking. Right. So if their smoking doesn't go down at all and they start using an e-cigarette, that's bad, right? Because now they're using more tobacco than they were before, and they have not changed their cigarette smoking. And that is potentially harmful. In all of my trials, I write and do that at the end of the trial, we'll assess use and dual use specifically, and then we'll intervene upon people who haven't reduced their smoking by at least 50% if they're using an e-cigarette. And I think that's important. It is dependent on whether or not people reduce their cigarette smoking. And most commonly, we find that among people who use the e-cigarette frequently, that there are reductions in cigarette smoking. And that's where that part where the e-cigarette has to be appealing for it to work. For COPD, when people switch completely from smoking to using an e-cigarette, their COPD gets better. And the data on that are pretty clear. Asthma and COPD get better. So it's a function of the combustible product use. It's not that potentially the e-cigarette doesn't reduce harm. It just shows that your harm, the bulk of it from tobacco, is dependent on your combustible product use. And I know that again, is I think people get scared to say that e-cigarettes are less harmful, but the FDA has said that some e-cigarettes are less harmful. That's why they authorize them. And the bar is really high to get authorized by FDA. So some of those tobacco flavors, FDA said, that it's clear that there's public health benefit because for smokers who switch completely, there's strong data that it reduces harm. So I know people get uncomfortable about that, but I'm not out on a limb on this. It's, something that I think a lot of experts agree on, and that the FDA, after reviewing the evidence, has said that for at least some products, that they've met that bar. Anyway, thank you guys so much. Yeah, I appreciate it. I'm happy to take questions via email too.